Hi, good afternoon, everyone. At the outset, thank you, Prashant. Thank you, organizers, for giving me this opportunity. And I know it's a post-lunch session, so I'll just try to make it more interesting. And please feel to interrupt me anytime in between. I think this audience out here doesn't need to, doesn't need a basics of what we are going to talk about. But nonetheless, I think immunotherapy in the lung cancer is what I have been requested to speak. And what's new? I think that's the next important concept and how the things are happening. So when I started my clinical practice 8-10 years back, I think lung cancer was just evolving. Thoracic oncology was supposed to be one of the fruitless subjects, but look how it has changed over the last decade, and it's somehow the survival of these patients, which was hovering in few months, has actually catapulted to few years, and now probably easily you could say that a patient with advanced non-small cell lung carcinoma could cross a barrier of 24 months. And I think all that has been attributed to improved supportive care, which is very important, and also the new drugs which will come into foray in this typically difficult to treat disease. So I think the statistics all of us are quite familiar with. Asia has one of the highest incidence and mortality rate for lung cancer because of the fact that most of these patients are diagnosed in an advanced stage and they have got a very poor background pulmonary reserves, and hence the outcome of these patients becomes quite tricky. Adenocarcinoma, initially it was squamous, but now adenocarcinoma is the predominant subtype, and I'm sure all the physicians out here would be seeing so many patients, females, never smokers, adenocarcinoma, and that incidence is rising and rising. And I'm sure my colleagues here would agree that almost more than half of the patients that we see in our clinics today are never smokers. They are females. They have never had an exposure to tobacco of any form, both smokeless and non and smoked tobacco. But nonetheless, these are the alarming figures, and it is indeed frightening. And hence, we need something. We need good drugs to manage these patients. So as I mentioned to you, let's go a decade back when you could put all of these patients in one box. Advanced non-small cell lung carcinoma, they were treated with the same cocktail, the same platinum-based doublet. Then the concept changed, and probably you could treat adenocarcinoma differently than the squamous. And then there was slight incremental gains in the survival. The survival which was hovering around, say, a few months with only base supportive care. Then came the platinum. It increased by, say, around 6 to 8 months. Then probably we realized that only platinum is not good enough. We probably need to add platinum with some chemo combo. Then it increased by another few months. Then we realized that, oh, let's not put squamous and non-squamous in one board. Let's try to tease them out. And if you could treat adenocarcinomas differently, squamous cell carcinoma differently with the different cocktails, then probably you could get a better results. And yes, we did get better results. Then came the newer and newer drugs called as a targeted molecules. And I'm going to allude to in a few of my next slides. And then actually a time came when you actually broke that 12 months barrier. And then again, it's open now that the barriers have been broken positively for the patients. And now we are looking at a catastrophically high survival rates in a patients with advanced non-small cell lung carcinoma. So this is how we used to treat them. As I had mentioned to you before, cisplatin or a carboplatin was a platinum backbone, depending on the performance status and the renal profile. And then we used to add one of these cocktails, or we would say soft drinks, gemcitabine, docetaxel, vinorelbine, or paclitaxel, depending on the patient profile and the histopathology. And as you could see here, in 1970s, 2 to 4 months best supportive care, 5 to 7 months single agent cisplatin. Then came the platinum-based doublet. Then came the concept of histological directed therapies. And then you have got anti-VEGF, then you got targeted drugs, then you got immunotherapy, and this question mark probably would grow even bigger and bigger as the size of the iPhone becomes big. So the most important concept here is that I think all of us know that there are driver mutations which are governing the cancer growth in large number of advanced non-small cell lung cancer patients. And if you could see here, there is a plethora of mutations which resonate in the landscape of advanced non-small cell lung carcinoma. But the one which I've highlighted here is those 42%. Almost half of the patients would not have any driver mutations. So we get excited with the driver mutation story. We get excited with gefitinib, erlotinib, and so many analogs which are there. But what about this large group of patients? 42%, and a lot of them are adenocarcinomas, large number of them are squamous cell carcinomas, for which they don't have any accompanying partner. So what do we do for them? So we have something. So we have what is called as PD-L1 testing, and we have what is called as immunotherapy for them, and that's the topic for today. So broadly, when you look at the helicopter view of the advanced non-small cell lung cancer treatment, we have got three treatment options. One is chemotherapy, then a targeted therapy, and then the third one is immunotherapy. And the targeted therapy is used only in those group of patients wherein there is an oncogenic driver mutation which is happening at the molecular level. So let us forget those 50% of the patients. What about the rest 50%? Then the option remains is conventional cytotoxic drugs, which I had mentioned to you before. And then there's a new baby on the block. It's no more new, but a baby which has probably changed the outcome of treatment of non-small cell lung carcinoma. So IO therapy is what we are talking about. Mind you, immunotherapy, you could see a lot of marketing gimmicks, a lot of vaccines being projected, but that's not what the immunotherapy which we practice in our day-to-day clinics. And I will probably get into the deep impact of those in few of my next slides. But broadly, the tumor environment has anti-tumor factors and pro-tumor factors. And these pro-tumor factors which are inhibited. So there is a, in the stroma of the cancer cells, there is an inhibition of pro-immune factors by the cancer cells, because of which there is an exuberant proliferation of oncogenic sort of growth signals, and then there is a new growth which has been seen. So the concept with immunotherapy is that try to inhibit the inhibition so that the immunity against the cancer cells both locally and systemically is stimulated. And one of the important mechanisms, as what has been seen in this particular cartoon, is PD-L1 and CTLA4. Just request you to highlight on this particular topic. PD-L1 and CTLA4 are the inhibitors of inhibition. And if you inhibit those, then you are actually stimulating the immunity against the cancer cells locally and systemically. And that's how you're going to achieving the apoptosis and cancer necrosis. So the inhibition of PD-L1 and CTLA4 is critical in augmenting the immune response against the cancer cells locally. And that's what the immunotherapy of Vogue, what we are talking about, does. So PD-1 inhibitors and CTLA4 inhibitors are the drugs which are currently used in clinical practice, which are either combined or given as monotherapy. I'll go through those, some of the slides down the line. But broadly to understand, there's PD-L1 inhibitors and CTLA4 inhibitors are the drugs which are used in the treatment of advanced non-small cell lung carcinoma, and that is what the immunotherapy which we talk about. There are other concepts in immunotherapy which have also been augmented. One, of course, as I mentioned to you, is the ICI, the immune checkpoint inhibitors, which is PD-1, PD-L1. We also have got adaptive cell therapies like tumor infiltrating lymphocytes and CAR T cell therapy, which are very well exploited in hematolymphoid malignancies. And then we have also those anti-cytokines, immunomodulating drugs, BCG, which is used in bladder cancers. So immunotherapy was always there in the treatment of solid and hematolymphoid malignancy, but it has been exploited to the T with the introduction of these inhibitors and, of course, a better understanding of the molecular biology of PD-1 and CTLA4. So this is what is going to be discussed today. So immune checkpoint inhibitor therapy, to summarize, is going to be inhibition of PD-1 or PD-L1 and CTLA4, and to augment the tumor response locally and systemically. So to simplify for my chest physician colleagues here, so these are the typical immunotherapy agents which are used in lung cancer, and I'm sure the list will increase as we speak. But this is what we have today. A drug called as pembrolizumab, atezolizumab, a combination of nivolumab plus ipilimumab and nivolumab as a monotherapy, durvalumab, and a drug called as avelumab. So these are the 4 or 5 important midfielder immunotherapy drugs which are used in clinical practice. These drugs, we have it at our disposal and we are routinely using it. The most important predictive test. So for example, when you have landed up with a patient with advanced non-small cell lung carcinoma who does not have a driver mutation, the next reflex test that we should be doing is what is called as PD-L1 testing. So this is a test which is done on immunohistochemical blocks, and it is a predictive of a response to immunotherapy. Now, as I mentioned to you, there are 4 drugs, and each drug has got its companion biomarkers. So a pembrolizumab has got a platform called as DACO. Similarly, there's a drug called as atezolizumab, which has got platform called as Ventana. I would not probably dwell too much into it, but conceptually, those patients who have got a high PD-L1 score or expression, they are the one who are likely to benefit with immunotherapy. And those who have got low or no expression, they are unlikely to benefit with immunotherapy. So how do we use this PD-L1 in our clinical practice? So those patients who have got a very impactful PD-L1 score, which is exceeding 50%, then probably these are the patients wherein you have a good response to immunotherapy alone. Then there are those patients who have got PD-L1 score between 1 to 49%. They have got moderate response to immunotherapy, and it is worthwhile not using them alone, but combine them as a cocktail with chemotherapy. And those patients who have got PD-L1 score less than 1%, then it is definitely no immunotherapy as a monotherapy, and it is always used in combination with chemotherapy. I'm going to bore you with few of the slides in terms of statistics, but I'll just highlight the important points, which are the selling point of a study and a point which is proving the impact of this drug in our clinical practice. So this was a large phase 3 study, and we've got follow-up of this study starting from 2016 up to 2020, 21 and 22, and the updates are coming and coming. These are basically the pembrolizumab was a drug which was the first line treatment of advanced non-small cell lung carcinoma in combination with chemotherapy regimen. The division was head-on, pembrolizumab versus platinum-based doublet, which is the standard treatment for a non-driver mutation patient. The primary endpoint was progression-free survival. Secondary endpoint was overall response rate, overall survival, overall response rates, and safety profile. The baseline characteristics of the patients were evenly matched. I would not want to go into the details of it. But look at this. The objective response rates upwards of 46%. And I think that means a lot in terms of the clinical benefit that the patient receives, because many of these patients are heavily symptomatic because of the disease burden in the lungs. So if you could achieve a response rate, even forget the survival, forget the progression-free survival, but a punchy response rates in a patient which is heavily burdened with disease could possibly improve his quality of life. And that is very important when you are looking at a palliative setting like advanced non-small cell lung carcinoma. You've got fairly impressive complete response rates. You're looking at partial response rates. We have never had complete response rates with chemotherapy alone in a non-small cell lung setting, but this CR concept has actually come with the advent of immunotherapy. And I think these figures are fairly exciting. This is just a 5-year update. So how did this patient go? So patient must have received combination of chemotherapy plus immunotherapy. Then they must have progressed. Then they would have received second line of treatment. And in spite of that, there is a huge impact of survival with this immunotherapy being included. And if you could see here, the hazard ratio is 0.62. So what it means that the patients who have received pembrolizumab plus chemotherapy had the median chance of survival upwards of 26 months. Whereas the patient who received only chemotherapy had got a survival of 13.4 months. So almost there is a doubling of survival by introduction of immunotherapy drug together. Again, 5-year updated on treatment duration and the response. And this is something which probably I would just dwell upon is the duration of the response. Typically what we see when you're using cytotoxic drugs, they have a response which is very transient, and then obviously there is a rapid progression of the disease. But what we've seen with immunotherapy and what typically is called as tail of tail phenomena, wherein the patient who has received immunotherapy for a long period of time continues to get a long durable response rates, and that's what we're looking at, an operational cure of this difficult to treat disease. So the duration of the response is quite punchy and deep, and that is an important selling point of using immunotherapy upfront setting. And at data cutoff, you could see almost 46% were alive without progressive disease and subsequent therapy for non-small cell lung carcinoma as per the investigator assessment. So almost half of the patients who have received this particular combination of immunotherapy plus chemotherapy are going to be disease or progression free. And I think that is fairly rewarding as far as this difficult to treat disease is concerned. Keynote 024, and then you got results of the timeline, as I mentioned to you before, that we almost have got 60 months of data. So the data is huge, massive, impactful, and it is actually showing that, yes, this is a drug which is working very, very well, 26.3 months versus 13.4 months, something which is crossing 2 years of the boundary, something which was unheard of in the treatment of advanced non-small cell lung carcinoma. As I just mentioned to you, pembrolizumab as a monotherapy would only be reserved for those group of patients who have got a very high PD-L1 score or those who are ineligible for cytotoxic drugs. Now, we see a lot of these elderly patients, 75, 80, who have advanced non-small cell lung carcinoma, who probably are not a candidate for cytotoxic drugs. They do not have the driver mutations. So what do we do for them? So probably we have a drug now, and we've had fairly decent response rates by using pembrolizumab monotherapy and many other monotherapies in this particular setting. So this is a very attractive treatment option for those elderly patients or those patients who do not wish to have cytotoxic combo and who have a very high PD-L1 expression. Then pembrolizumab or any other immunotherapy I had mentioned to you before could be used. So again, this is forest plot which is showing that it works in all patients. It works in squamous, non-squamous histology. Squamous did not have anything before. So we have a drug which is working in this group of patients as well. It works in smokers, non-smokers. In fact, there have been studies which is showing that in smokers, it works slightly better than the non-smokers. And we probably don't know why particular phenomena happen. But again, we have an option for this difficult or this tricky patients as well in our clinical practice. This is again a final analysis by PD-L1 more than 50%. And as you could see here, with a single monotherapy of immunotherapy, you have a response rates and the median overall survival of 22 months versus 10.8 months. Again, doubling up of survival with the use of this particular drug. And you could see the curve is separating, and probably another 24 months, we would have a very more impactful data for these drugs again. Again, for PD-L1 1 to 49%, which are the gray zone patients, again, monotherapy has got fairly good response, but in our clinical practice, most of my colleagues, I think, would agree here that we tend to use immunotherapy in combination with cytotoxic drugs for achieving better response rate, because these patients have got a very high tumor burden. So again, 3-year updated overall survival rate, response rate, and duration of response, again, punchy, very, very deep, very long-term response rates as what we could see with the use of immunotherapy. So this is just a broad guidelines as to how we would treat a patient in 2022 when he walks into it with a diagnosed with a stage 4 non-small cell lung carcinoma. Again, they would be broadly divided. First, those with driver mutations, and there are almost those 40% who would have a driver mutation, and we have drugs to target those. But there are those last 50 to 60% of patients who do not have driver mutation. They do not have a companion. So probably these are the patients wherein PD-L1 goes in, and if the PD-L1 comes more than 1%, then it's a combination of immuno plus chemo. If the PD-L1 is very, very upfront, very, very big, then it's probably immunotherapy alone. And those patients who have got PD-L1 less than 1%, immuno plus chemotherapy combination continues to hover and resonate the landscape of advanced non-small cell lung carcinoma. So my take-home message is that ICI, that is immunotherapeutic agents, has dramatically changed landscape of advanced non-small cell lung carcinoma therapy. PD-L1 testing is the key decision maker and a very, very important predictive marker for response assessment of immunotherapy. Immunotherapies are not to be used in driver mutation positive patients. This is very important. Somebody who has got an EGFR mutation positive, then he should go for osimertinib, erlotinib, and so on and so forth, because it has been shown that the immunotherapy has got a detrimental benefits in this group of patients. Longer duration of responses, unprecedented survival are key highlights of the ICI therapy. Safety profile, which my colleague and my dear friend Dr. Muzammil is going to allude to in subsequent talk, is fairly manageable and significantly better than the conventional cytotoxics. With this, I conclude my talk, and I thank you all for the patient hearing. Thank you so much.
Thank you, Dr. Joshi. The House has any questions? I can ask one question.
Sure,
I'm a chest physician, academician.
Sure.
So now, if I have a patient with a chest tube, a malignant pleural effusion, we have so many coming, receiving those. We have advanced NSCLC cases.
Yes,
okay.
Yes.
So like this lady, 6 months of whatever, your chemotherapy available in institute. So I mean, would immunotherapy be okay to a patient who has a chest tube or maybe probably a thromboembolism?
Yeah,
There's
absolutely.
no as such a contraindication.
Absolutely.
Or not to be given or something like
No,
that.
no. So I think for thromboembolism issue comes when you're using a drug called as bevacizumab. So that is the time when it is becomes a relative or an absolute contraindication. With the chest tube, absolutely no problem. When the effusion is there, when you're using pamitrixate, make sure that the chest is dry. That's it.
So we'll go ahead with the next talk.
Thank you.
To introduce the next speaker, I hand over to Dr. Jairas.
Thank you, Dr. Joshi. Wonderful talk. It actually kind of helped us to, change the way we look at, medical oncology after this talk. So now that I'm keen to know more about PDL1, my dearest